Hello, everyone. Welcome again to another episode of the Doctors of Cleveland Clinic, Abu Dhabi. Today, we will be talking about an important topic, which is the pulmonary embolism. We'll focus on the evolution of the management of this condition and specifically the role of the Pulmonary Embolism Response Team, also known as PERT. To do that today, we have two experts joining us for the discussion. First, Dr. Batool Abuhalimeh, who is a vascular medicine consultant and the director of the PERT team at the Cleveland Clinic, Abu Dhabi. And on my right is Dr. Chen, a consultant vascular surgeon at Cleveland Clinic, Abu Dhabi, with a special interest in the treatment of venothromboembolic disease. Welcome, doctors.
Thank you.
Thank you.
So pulmonary embolism is a very important condition. It's very lethal. It's causing more than 1 million deaths a year in Europe and more than 200,000 deaths in the US yearly. That brings our attention that the need of timely treatment of such an important disease. To summarize, pulmonary embolism usually originates from thrombosis in the deep veins, usually the lower extremities, less likely the upper extremities, that dislodges and lands in the lung. That causes malperfusion of that part of the lung and prevents the exchange of oxygen at the level of alveoli and blood vessels, causing hypoxia, a lot of strain on the heart to push the blood against that obstruction, which strains the right ventricle and sometimes causes the malperfusion of the entire body, causing hypotension and syncope. In addition to arrhythmia and so forth. The combination of all these can be very lethal. Therefore, treatment of this disease has to be timely. And thus, that's bring us to the role of PERT. So, Dr. Abuhalimeh, tell us what's PERT and why is it important?
Absolutely, that's a great question. So PERT, which stands for Pulmonary Embolism Response Team, is a multidisciplinary team-based approach. What happens is that this brings out different people or different experts from different teams to come down together in order to do a couple of things when it comes to a patient who has pulmonary embolism. One of the most important things is the actual timely diagnosis, as earlier suggested. The other thing is risk stratification of those patients that practically help us to identify the prognosis of those patients and the appropriate treatment for those patients as well. And then the most appropriate modality in order to treat those patients. Should we go for anticoagulation treatment alone, or are they candidates for a possibility of an intervention? Now, at the Cleveland Clinic in Abu Dhabi, we are very proud and very happy to have a multidisciplinary, comprehensive PERT team that consists of different experts in vascular medicine, vascular surgery, cardiac surgery, intensive care, pulmonary medicine, and our ECMO or our shock team on board. Whenever we do encounter a patient with diagnosis of pulmonary embolism, this PERT team is actually called and activated. And then all of those teams will come down together in order to discuss this case, to decide what's the most appropriate approach for treatment and management of this patient. And the decision is usually done in a very timely manner to ensure that the patient does not deteriorate and we're taking the appropriate action in the appropriate time, and then we see where to go from there. Once the decision is practically made, the decision is implemented, and follow-up with the patient is done, whether it was inpatient or outpatient.
Amazing. I think this is great, efficient utilization of resources and multidisciplinary approach to such a lethal disease, especially from the lessons learned from the STEMI team in treatment of MI and the stroke team for treatments of stroke, even code blue for treatment of cardiac arrest. And we saw that time is tissue. Timely intervention means saving lives. And I think the PERT is another component of this algorithm.
Absolutely.
So, Dr. Chen, now that the PERT team is activated and we identified the patients that needs some intervention, or we know that they have pulmonary embolism, let's say, so what would be next?
So just to kind of piggyback on some of Dr. Batool's comments, we have a fast, real-time discussion among these multiple specialties to decide on the treatment. and that'll be based on several factors. But before getting into that, I did just want to emphasize, the multidisciplinary role of this team. And I think that's really important, breaking down those barriers, because in my mind, this has been, like you said, a lethal disease, but also almost kind of an orphan disease, not because it's so rare, but because it's so common. It happens to everybody. It happens to surgery patients. It happens to cancer patients. It happens to healthy patients, people just on an airplane and passing through Abu Dhabi. We've treated patients just like that. But to move on from there, getting together our specialists, we examine the data that we have, namely CT scans of the pulmonary embolism and the heart especially. And in addition to that, the blood work of the patient and the vital signs. Like you said, this affects the alveoli, this affects the oxygenation. Beyond that, it's not just a pulmonary disease, but it's a circulatory disease. And what kills people in the fastest way is that failure of the right heart. And so those are the factors we're looking at, namely the blood tests of troponin and BNP to see how their heart is straining or not straining, and then looking at some of the imaging factors on the CAT scan, the ratio of the right ventricular size to the left ventricle. And beyond the CT scan, what we're fortunate to have here is a very rapid capability to do echocardiograms informally at the bedside or more formally through the cardiology lab. And if we're seeing right ventricular strain on any of those imaging, either the CT scan or the echocardiogram, plus elevated blood markers for the BNP or troponin, that patient is now an intermediate high-risk pulmonary embolism. And that technically meets criteria for doing an advanced intervention like pulmonary thrombectomy or thrombolytics. If they don't have those factors, either of them, the imaging or the blood work, or only one, we might try to just manage them with anticoagulation, generally speaking. But all of these factors are also taking into account the patient's baseline health, their comorbidities, their bleeding risk, their weight, their ability to tolerate a procedure with or without anesthesia, and having that expertise from multiple trained specialists dictates what we do next.
Excellent. So for the non-vascular surgeon, can you tell us what you mean about thrombectomy or catheter-directed thrombolysis?
Yeah, so the treatment for pulmonary embolism has been rapidly evolving over the past several years. To date, the older thrombolytic treatment of the patient was just giving them systemic thrombolytics through a regular IV at a very high dose. And while that can be effective for breaking up the larger parts of the clot, it doesn't totally remove it, and there's a high bleeding risk associated with that. Evolving from systemic thrombolytics, we got into catheter-directed thrombolytics, where under the X-ray machine in the interventional radiology lab or vascular surgery hybrid room, we would go in and place small little catheters and tubes and then drip that thrombolytic into the patient, previously up to 24 hours and more recently even as little as 2 to 4 hours, with changing protocols and regimens that we have been finding to be effective. But some of the downsides to that catheter-directed thrombolysis is that you're still giving thrombolytics, which is, a step up from anticoagulation, and you still have bleeding risk associated with that. Now, over the past about 5 years or so, we've been developing more rapid technologies, namely thrombectomy catheters, and these are large bore catheters, sometimes 24 French. That's almost up to a centimeter of tubing going up through the veins, usually in the groin, sometimes through the neck, still under the X-ray machine, and then snaking that through the heart and into the lungs, and then directly sucking out all of that clot in one go. And with practice, we've been able to perfect our procedures and get some of those procedure times down to even 45 minutes or less. And from there, the patient can just go back to their room. I like to do these procedures without any kind of anesthesia, but we just kind of talk the patient through it, let them know what we're doing, give them local anesthetic so that they're not feeling too much with the catheter. And people really tolerate this well. And then they get back to their normal activities a lot faster. They get out of the hospital faster. They get out of the ICU faster. And the emerging data right now is that there's a lot less people dying from pulmonary embolism too.
This is impressive to see the evolution of the management of PE, how you have the technology and the devices, and you can maneuver the heart, and the skills that requires to maneuver the heart, the major vessels go into the lung selectively and suction that clot out or lyse it selectively without having the systemic effect, which brings us to the question of, so what happens next? What do you see after this patient comes out of this short, safe procedure that can be done under local anesthetic through a small puncture in the leg?
So just like Jason mentioned, usually patients, once they're done from their hospital stay, they get discharged out of the hospital. Now, what happens with those pulmonary embolism patients, and from what we have been seeing throughout the experience, a lot of those patients, they fall into cracks. They don't really know, who am I supposed to be following up with? Should I follow up with my primary care physician? Should I follow up with my hematologist, cardiologist, pulmonologist, or vascular specialist? And this is why at the Cleveland Clinic in Abu Dhabi, we do have the post-pulmonary embolism clinic. And this is a very specialized clinic space for those patients to make sure that they follow up with their physicians and make sure that they're taken care of. Now, what we actually do in this clinic, the most important things that we do is, one, we try to understand, why did this patient develop the blood clot from the first place? Because this way we could prevent recurrence of this blood clot. So we work up those patients. We do hypercoagulable panel for those patients. We try to understand, is it a malignancy-related blood clot, maybe an underlying malignancy that we need to work up and look into? Is this patient hypercoagulable? Do they have any genetic predisposition to blood clots? Is it because they used any hormonal therapy or any particular type of medication that we need to look into a little bit closer to prevent the recurrence of the medication? Afterwards, we also need to make sure that those patients are followed up closely, because most of those patients are still discharged from the hospital on anticoagulation therapy or blood thinners. Now, blood thinners are a high-risk medication because they increase the chances of bleeding in those patients. Although necessary in patients who have pulmonary embolism, these patients still need close workup. And that's why we follow up with those patients to make sure that they're compliant with the medication, they're tolerating the medication well, they are on the correct choice of anticoagulation, and if not, we could always switch the choice of anticoagulation as found appropriate. Another very important thing that we do in our post-pulmonary embolism clinic is that we look up those patients to see if they are developing any of the post-pulmonary embolism complications. One of them is a condition called CTEPH, which is a type of pulmonary hypertension, which means because of the pulmonary embolism or the blood clot that developed in the pulmonary vasculature, the blood pressure in those vessels in the lungs actually increase. So those patients may have persistent shortness of breath or signs of heart failure. Another condition is CTED, which means that they do have some chronic thrombi in the pulmonary vasculature, but they don't really have evidence of pulmonary hypertension. Another condition is post-pulmonary embolism syndrome, and we also make sure that those patients are followed up closely when it comes to their psychology, because there is a new term which is evolving when it comes to pulmonary embolism, which is called thromboneurosis, which is one type of PTSD that happens to patients who have pulmonary embolism, especially those that have life-threatening massive or submassive pulmonary embolism.
Wow, so now that's really good to know that PERT and the structure we have is not just prevent the acute consequences of the pulmonary embolism, but also the long-term one. Because as we know, the patient that treated with anticoagulation alone, 68% of them will develop right heart failure with the consequences you just said about pulmonary hypertension and so forth. So, Dr. Chin, now that the PERT is established, it's well running with multidisciplinary approach, What difference did you notice in your practice from intervening on these patients and the outcome?
Yeah, so I think there's been really some remarkable outcomes that we've had here at the hospital and other ones that I hear across the world. But basically, it really shortens the length of stay necessary for these patients. Previously, a person would come in with a pulmonary embolism, and unless they were decompensating, unstable, and really needed systemic thrombolytics before these other interventions had been invented, they would be on anticoagulation. And this clot, if it is going to break down, usually takes weeks to months. And so they would be sitting in the hospital, probably feeling a little bit better with the anticoagulation, but still pretty limited. And we still didn't have a great way of knowing whether they would decompensate if we sent them home. So they might stay in the hospital being watched for some unspecified length of time that we would eventually say is enough and then send them home. And they would still probably have, shortness of breath going up a flight of stairs or doing other activities that they would otherwise, that would otherwise be part of their normal life. Whereas with these more rapid interventions, they can feel normal even on the operating table. We'll have patients that, again, we're doing these procedures even awake with minimal anesthetic, and we take the clot out, and the patient right there on the operating room table will see their heart rate start to correct, we'll see their oxygen start to correct, and they might even tell us, doc, I feel like I'm breathing better right now. And so once they get upstairs, they're ready to get out of the intensive care unit where they may have otherwise spent 2 or 3 days. And then from there, they're ready to get out of the hospital where they may have spent 5 days to a week even. So that to me is just an amazing, really visible, tangible outcome difference compared to what we were doing before. And then again, also knowing that these patients could have been waiting in the hospital for who knows what, we didn't know, and then decompensating and possibly dying, and we're not seeing that happen anymore.
No, I agree with you. I find it very satisfying, exactly like you put it, is like when the patient can breathe easier, you feel the satisfaction. You almost feel that breathing easier there after such a relatively, it's not simple procedure. It's a procedure that requires a lot of skill, but it has its own risks as well. And then the immediate satisfaction, and then the long-term effect on the patient, including, as you mentioned, improving quality of life, is very satisfying and rewarding. So we see that the management of pulmonary embolism is advancing very fast, and we see that yearly, monthly, as you both mentioned. What do you see the future of the management of pulmonary embolism?
So one of the things that we're working on at the Cleveland Clinic in Abu Dhabi is integrating AI when it comes to treatment, diagnosis, and management of patients with pulmonary embolism. A lot of AI modules have been used for risk stratification in patients with pulmonary embolism, and that practically helps in timely diagnosis and timely decision-making process regarding the management and the treatment of those patients. One other thing that we are very invested in, and we have been working a lot at Cleveland Clinic Abu Dhabi on, is the PERT registry, which is practically looking into patients that we have encountered since we started the PERT program at the Cleveland Clinic in Abu Dhabi, and trying to understand their pathophysiology, their outcomes, their prognosis, procedures that have been done, morbidity and mortality. And this practically helps us in understanding the population in this region of the world, because unfortunately data is very scarce when it comes to thrombosis, pulmonary embolism, and thromboembolic events to people in this area or this region of the world.
That's great. That's another great point that you're contributing to the data now that we have more than anecdotal data or experience. It's just more finding and learning more about those patients and contributing to medicine in general and how to improve our treatment of this disease because, again, learned lessons from myocardial infarction or stroke made a big difference in patients' management. What do you see the treatment in the future of the interventions?
Yeah, so like I said, these technologies are rapidly evolving, and fortunately here at Cleveland Clinic Abu Dhabi, we have access to all the newest devices, and fortunately between us, the experience with them, I think, to use them effectively. Even now, there's still other kind of disorders on the spectrum of pulmonary embolism, large, high-risk right heart thrombus, high-risk SVC and IVC thrombus that were previously, again, just being treated with anticoagulation that we're now being able to get to and really nip in the bud before it even becomes a pulmonary embolism, but would otherwise have been a really high-risk surgery or intervention to do for the risk of knocking off that piece of clot from the right heart or the IVC and sending it into the pulmonary vasculature where we wouldn't have been able or willing to go before. So I think it's really exciting, the types of devices that are coming out and the tweaks that are being made to it to further optimize them. And then beyond that, just the excitement and the interest of physicians and other practitioners in the treatment of pulmonary embolism, whereas some of these people may have been swept off to just their primary care physician, who may or may not have had an interest or expertise in treating pulmonary embolism, or they may have not just followed up with anybody at all. And now we have these PERT teams where specialists from multiple fields can take an interest and have an elevated ability to treat pulmonary embolism, both in the acute phase and in the follow-up phase, and then into these other kinds of, post-PE diseases that Batool was mentioning before. I, for one, am I'm happy to put a plug for our other specialists that aren't here on the podcast today, like thoracic surgery and some of the things they're doing with pulmonary endarterectomy. I'd be happy to hear a podcast about stuff like that. And those types of interventions that I think are becoming more common, more effective, better studied.
Actually, that's a very good point, yes. In addition that we have the PERT to treat it timely, there were unfortunate patients that they were not treated timely due to lack of resources or the diagnosis wasn't done timely, and they develop these long-term consequences. And when they have the pulmonary hypertension, we have the expertise to perform the, as you mentioned, pulmonary artery endarterectomy and relieve them symptoms. That's actually another very good point, that we have the full team. So I think it's, kind of summarize everything. Although today we're talking about the management of pulmonary embolism, still the first line treatment of pulmonary embolism is prevention. We should prevent it. It's a preventable disease, but when it happens, it can have lethal consequences that needs to be recognized, diagnosed, and intervene timely and correctly. And the patient will have significant improvement in outcome, short and long-term outcomes. I think it's very assuring that at Cleveland Clinic Abu Dhabi, we have the resources, the technology, the skill set, as well as the structure, like the PERT team, where we can efficiently identify, diagnose, and treat those patients. Any last words to our audience?
We are here at Cleveland Clinic Abu Dhabi, well equipped to treat pulmonary embolism. We have an interest in it, we have the capability to do it, and we have the ability to follow them up.
Excellent. Thank you so much for your time. We would like to thank all the audience for joining us, and please reach us with any questions. Thank you.